Welcome to the Digital Healthcare Experience, brought to you by Taylor Healthcare. Welcome to the Digital Healthcare Experience. I'm Naomi Schwimmer with Taylor Healthcare. We are here to discuss informed consent for today's digital world. Thank you all for joining. So we have a great panel of healthcare leaders for you today. I'm excited to introduce them to you. We'll get started with Courtney Bruce, Associate Chief Experience Officer at Houston Methodist Hospital System and Associate Professor at the Institute of Academic Medicine at Houston Methodist, and an adjunct professor at the Texas A&M Health Science Center. Courtney is a nationally credentialed clinical ethicist and a leader in clinical and bioethics. Dr. Stecia Selski is a nurse informaticist at UCLA Health, and she's been working in the field for 9 years and is board certified as an informatics nurse. Dr. Selski currently focuses on several areas, including informed consent, inpatient workflows, remote patient monitoring, and telehealth. And we have Kristen Dennis, Director of Risk Management at Jackson Health System, and a seasoned professional with over 27 years in a seasoned nursing professional with over 27 years in perioperative services. Kristen is also an educator and monthly content contributor for AORN, the Association of Perioperative Registered Nurses. So thank you all again for joining. Very excited about the insights that you'll be sharing with us. And now on to our moderator, Doug Stefano from Taylor Healthcare. Thank you.
Thanks,
Doug.
Naomi. Appreciate it. Thanks. Welcome, everybody. We are excited. As you can tell, we have an awesome panel. My background, I am the Vice President of Sales here at Taylor Healthcare. 30 years in the healthcare business, calling on the industry, and I am not the expert on this call, so I will leave the tough questions to them, but I will try and take us through and keep us flowing. And if you have questions, please use the Q&A feature, and we'll do our best to either get to them at the end of the forum, or we will answer them and get them out to everybody that's a guest today. So, all right, panel, let's get started. So I'm going to throw around the horn to all of you on this one. Let's just talk about the basics. What is informed consent? And I'll just go left to right on my screen here. Stecia, why don't you start us off?
So informed consent at my organization is a policy that refers to the process by which the physician provides the patient with information such as risks, benefits, and alternatives to an invasive procedure. Our physicians are responsible for identifying those procedures in which cases a patient will need a consent, and they're also responsible for their actions with the patient and making sure that it gets documented and signed by the patient.
Okay, thank you. Kristen?
So we have about the same process for us for the informed consent. Again, this is something that the patient is going to be knowing what's going to be happening to their body, and they have the right to decide whether or not they want to have that treatment done. Here at Jackson, a PGY-1 or above can get an informed consent. But again, the most important thing about this is that the risk and benefits about the treatment that are about to be done is going to be explained, but also what could be some of the possibilities during the case that's going to be happening with an informed consent. So, and again, the patient may sign a consent, but they have every right up to the very last minute before induction to say, no, I do not want to have this done. And we respect that.
Awesome. Thank you so much. And Courtney, if you could weigh in as well.
Yeah, I'm actually going to take a little bit of a different angle in that my co-panelists focused very much on the documentation or the paper aspect, and maybe even a little bit of the process. But even before then, at a more fundamental level, informed consent is a dialogue. The whole purpose of informed consent is to make sure that the patient has a good sense of what they're getting into and that they know the alternatives to it. And the documentation is really more the kind of ceremonial stamp at the end of the dialogue, a very legalistic mechanism to show that we had the conversation and that the patient knows what they're getting into. But fundamentally, the core components of informed consent is that the patient comprehends what you discussed, that you did enumerate the risks and benefits and alternatives, that the patient is voluntarily going into the surgery or procedure, and that they articulated a choice. The documentation is actually just a component of that overall dialogue or process. So a little bit of a different angle, less legalistic than my co-panelist, which is interesting because that's actually my background. But
because you're the lawyer.
I didn't want to lose sight of that kind of the
Courtney,
fundamentals there.
I think it's actually a really good point, because that dialogue and discussion sometimes for us happens at a different point in time than when the stamp is made.
Yeah.
So that conversation actually happens before our procedures are scheduled, or at least ideally we would like it to be. But then sometimes the stamp of we have this conversation, I'm signing it, this is my choice, can happen the day of surgery or procedure or later. So it's interesting that I think it's very accurate, because they can be at different times.
Great point.
And I agree.
Thanks, Kristen. So we have an interesting kind of statistic out there that I just was reading about, that 50% of patients will consent to a procedure just because they want to get the procedure done, whether they understand it or fully have the alternatives, risks, and benefits, outlined for them, that they'll, and that's a scary kind of concept, right? That half the patients that come in are going to consent just because they want to have the procedure done. So along those lines, Kristen, this one's for you. Tell us the difference between like a general consent to treat versus a procedural informed consent. And what do you think regarding that?
Well, to me, a general consent is an umbrella consent that you're actually signing before you're getting admitted into the hospital, saying, yes, I understand that going forward, they're going to do a physical assessment on me. They're going to be doing routine labs. They might be doing EKGs and echoes. And all of those are covered within the general consent that somebody signs. And we're all used to signing that paper and have them saying, well, this is just to make sure you understand. And so we can bill your insurance. And it's usually done right upon admission and it's signed. For me, an informed consent, on the other hand, is a whole conversation that's happening about what you're going to have done, why you need to have it done, the risk and benefits if you don't get it done, and also to make sure the patient comprehends exactly what's going on, because that's the most important part. Because even though they may have that conversation the first time, may at the clinical office, but even the day of, the surgeon will still come by and say, do you have any other questions? And they'll be like, they bring out their paper. Oh, yes. After our last conversation, I Googled this, or I have 15 other questions related to this because my family all opined. What do you feel? And again, they get that information and that gives them more time to digest exactly, especially what's going to happen after. So for me, those are two different things. One is, you're about to touch my body. What are you going to do? That's my informed consent. The other one is, you're going to come in, we're going to do all this stuff, and we want to be able to bill you.
Well, thank you for that. Awesome. The billing part is very important. I get it.
It is.
So Courtney, for you, so when this process is just, let's say it's poorly executed, the whole informed consent process is poorly executed. How would you say like patient experience, safety and quality are impacted at an organization?
Oh goodness, they're impacted tremendously. And I should say that the poor execution isn't always on the healthcare team or the physician or the surgeon.
I would agree.
Sometimes the patients are just as equally responsible. I'll be honest. I think most people would say I'm generally fairly educated, well educated. I like to stay informed, but I will be the first to admit there have been many conversations where I've just kind of quickly signed something or digested what was being said and not really retaining it. So there are a lot of different reasons that something can become poorly executed. But from a quality standpoint and just from a patient experience standpoint, what happens is the patient may feel that the whole conversation was rushed, that they didn't really know what they were getting into. The recovery is usually impacted because they didn't know what to expect in the post-operative period or what they should do to manage their healthcare. So then you're going to see a negative roll cascade effect impacting their readmission rates, their ED revisits. I mean, we know from an informed consent perspective, the more in depth the conversation is, not necessarily just listing out a whole bunch of stuff, just the richer, the higher quality that conversation is and what the patient can expect, not only during the surgery or procedure, but post-op too, the better they're going to do. They're going to know what they need to do to help manage their care, which really can impact us at an institutional level. So, the patient experience, well, that's what I do. It's usually symptomatic of a deeper problem. Usually when you see negative patient experience hit from the informed consent perspective, there's going to be some quality issues and maybe even some safety issues.
Awesome. Thank you so much. So I know you have your JD, and so from a legal perspective, I have to ask, what constitutes a properly executed informed consent?
It depends. It is a little bit state specific.
Well, yeah, and so I know
So
Texas has special laws.
yeah,
And, we got to
we're
solve for all the
Texas.
different things there with the
Yeah,
Texas risk panels, but
Texas really tries to articulate what we consider to be sufficient risks, or articulating risks that if you covered them, then you're kind of safe from a legal perspective if someone were to try to sue you. But for most states, what they're looking for is articulating the risks and benefits, and risks being ones that are likely, that are possible going to happen, even if they're remote. So death is usually expected to be discussed, because many of us put a lot of value on death, even if the chance is 0.0002. So you want to mention risks that have a high risk of happening, or even a fairly reasonable chance of happening, and risks that maybe are very, very remote, but yet would be really seriously impactful if they were to happen, like death. So most states from a legal perspective are looking for what a reasonable patient would want to know. And most reasonable patients would want to know what they can expect. Very high, if something is a high risk of happening or reasonable chance of happening, or if there's a low chance of it happening, but yet it would be seriously impactful. That's generally what we're looking for from a legal perspective.
okay. So I have to ask you, just because this comes up frequently, and we've been talking about, the informed consent process, and I hear physicians say all the time, like, oh, I never get sued, or even if I get sued, the informed consent process isn't part of it. But I also understand from some of my legal friends in the business that say that's the number one thing kind of that they access, right? Is, what was documented around the procedure that happened. Is that the case? I mean, do you see that is the case?
Yeah, it is. It is one of the very first things that's looked for, just because it is required of us, and it's sort of the bare minimum to for good quality care, is to make sure an informed consent was completed. And it's very easy to tell whether it wasn't done. So it is looked for very easily. But I will say it's hard to sue on it, because most of the time, if there's some documentation that shows it was done, it's very hard to show that it wasn't a sufficient process. So there's a little bit of truth to both perspectives. Both the physician saying, I've never sued on it. Well, that's because it's really hard to prove that you didn't do it.
Right.
And also it's accurate that your legal friends pointed out that it is something that's routinely looked for in absolutely every case involving healthcare. I can say that with confidence, just because it's an easy check whether it was done or not.
I got one last little question on kind of tying on to all this. And one of the things we're hearing in the market is these big healthcare organizations asking their physicians to potentially start recording the conversation. Have you seen that as part of kind of the next wave of informed consenting?
No, I will say no. I haven't seen the recording aspect, but I will say people are very much moving away from paper, because we just see there are just too many problems with paper. I can't tell you how many informed consents I've run across, and I'm sure my colleagues on the line have come across, where people have scratched it out or initialed it at a different date, or there's some really terrible writing and you're trying to make it out, or you don't actually have a signature, but the conversation happened. Or that it's ripped on the, it's not actually embedded in the chart in an electronic way, which is not really capturing what happened. It's just, paper is problematic in all aspects, not just informed consent. It's problematic in just healthcare in general. The cases move too quick. There's too much moving on, going on. The patient moves too often. So we're moving to digitization. I will say that, but I don't know that we're necessarily moving towards reporting. At least I
Yeah.
haven't experienced that. I don't know.
Yeah, it's interesting. I just didn't know if it was a trend that we should expect, but your segue was perfect because, you know, as we sit here as Taylor, the second largest printing company in the world, and I started in the business selling literally documentation to hospitals. That's what I did all day long, every day. Stesha, I know your organization has moved to the digitizing of the consent processes and gotten out of paper. Why do you think digitizing the informed consents should be a top priority in healthcare?
So there's actually a couple of big reasons. You know, one of the first ones Courtney already mentioned is that when we have an auditing agency come by or a lawsuit come up, you know, for example, CMS, Joint Commission, Department of Health, any of these agencies who come up and they show up to our hospital and say, you know, we would like to review some cases with you. We'd like to review your process. Anytime we have a patient who's at any semblance of a procedure, the first thing that they ask for is show me the consent. Does it have a signature? Does it have a date and time? Let's look at the physician's note for what he put in here about what he discussed with the patient. Because I think this is a two-pronged issue here. One was the conversation with the patient had? Did the patient have capacity to have that conversation? If not, did they have that conversation with a healthcare power of attorney, some sort of a surrogate health agent? Was that documented correctly? And then the second piece of that is what kind of conversation did they have with the patient and what did we write that down as? Because a lot of our paper consents that we had before we digitized them, in every single nook and cranny in every single department, they were all very different. Some physicians had very complex language that you couldn't read at all. Some physicians had way too much information that wasn't pertinent to the procedure and listed out all of these other procedures that they could consider. It was confusing to patients. And so standardizing the content, making sure that the patient has the capacity and the literacy to comprehend it, and making sure that that is presented at a certain reading level for all of our patients. And then also language barriers. We have to make sure that we have it available in different languages. And I know that's a barrier for a lot of organizations today. And this is one of the top decisions that patients are going to make for their healthcare, whether or not to have an invasive procedure. So this is a critical process. It's very important to the patient experience to make sure they understand what they're getting into. But it's also really important for organizations because it's something that we need to have available for patients to see. It is something we need to have documented, but more importantly for patient safety. I think one of the top reasons is patient safety, because this is one of the few documents in the workflows we have that will follow a patient throughout the entire stay of a hospital. You know, you get admitted and then you go to the PTU. You could be coming down from a nursing unit. You could already be in our hospital, and the inpatient nurse is going to check. Do you have the consent? Have you signed it? Do you understand? Our pre-procedure nurse, do you have a consent? Have you signed it? Our OR nurse, our timeout, we're all going to look at it and make sure, are we performing surgery on the right side? Are we consenting for the correct procedure? Is this the right patient? PACU, they're going to make sure the same thing. And then later, it's going to be in the patient's records. And when we have it on a piece of paper, as Courtney already alluded to this, there can be writings crisscrossed out, cannot be signed, and then we lose it. It follows the patient throughout the entire procedure process, and then it doesn't get scanned in because during this whole process, it was probably in the patient chart, which was in the patient bed, and then at some point it fell out. It got lost because it gets taken out so many times. If you hole punch, it eventually just breaks and falls apart. So for us, digitizing our consent was incredibly important, not only for our patient experience, but for our record keeping, but also just for the safety of patients so that we make sure that we're performing the correct surgery. The patient has consented to this surgery, that it's on the right laterality that we've decided for the patient, and that we're all looking at the same consent. Because when it's on paper and you lose it the first time, you fill out a new one. Did you fill out the right one? Did the patient fill out the correct one? Did it change? Did we mark any edits on it? Can you read it? There's just so many issues with it. So that's a few issues with why I think it should be prioritized in healthcare.
Awesome. So kind of adding on, right? So, you know, with the proliferation of the EMR and all these big millions and millions of dollars of investment that all your health systems have made, why is it that the last workflow to be digitized is informed consent? Like, it's so important, but we'll get to that down the end of the line when we get to it, right? So like, do you have any input into why it's last?
Yeah, lots of input. Actually, there's a couple reasons here. One is because just like the consent follows the patient throughout the procedure process, a consent and this informed consent dialogue that we have with a patient can be performed in so many settings
Sure.
and at different points during the patient's care. During the pandemic, telehealth visit, a telephone call, video visit, in a clinic. The conversation can happen in a clinic, but we sign it in the pre-procedure unit, in the outpatient surgery center, in the OR. We can sign it at all these different points in time. And there's also rotating surgical teams. So whose responsibility is it to have the conversation with the patient and then to help the patient sign the consent and then find the consent once it's been signed? And what are we pulling up and looking at? So for us, the first piece of that was really difficult is, all of the different workflows that you have to address when having the conversation and then documenting it. It can happen in all these different settings. The second piece is the content. Some organizations decide, well, we're going to have just a couple of general consents that are not specific to any procedure. The provider's going to type in the procedure name and give the patient some sort of an education sheet. But a lot of health systems are not fond of that. It doesn't specifically lay out all of the risks and benefits, potential alternatives, reasons the patient may want to do this. And so if you're an organization that really needs thousands of consents for all of the different procedure types that you do, that becomes a problem. It also becomes a maintenance problem. Building thousands procedural consents into Epics or in any of these areas for an in-house IT team is nearly impossible because there's no way for us to maintain all of the content. Part of the other problem is whose responsibility is it to update, approve, read through, review, make changes to that content. When we're on paper, you probably have all had this experience where everyone has a piece of paper, they have one consent, they print out 300 copies per clinic, and they use it for years and years and years. The consent probably got updated at some point, but we never see the update because we're still using the print paper copy that we printed out years and years ago. And also, physicians don't want to let go of their content. They have their specific content that they want to use. So standardizing content and our process is very, very difficult. I also think getting a patient signature, building an interface, building a workflow that's going to work for everyone is also very difficult, which is why I think that this is one of the last workflows to be adopted.
Awesome. Thank you so much. That was a great answer. So, Kristen, I'll turn to you. So I know Jackson has also digitized their informed consent process.
Mhm.
What are some of the challenges you guys experienced when you did this, when you kind of embarked on this journey?
So again, just like it was already preset already from my other colleague, there is so many stakeholders involved when it comes to an informed consent. There's so many meetings that had to be have in order to make sure. We just recently did another process where we added something into our consent. And with that process alone, we had meetings upon meetings with stakeholders to verify everybody was happy. And even when we rolled it out, we still had to go back and do more re-education because there were certain groups that sort of missed the whole input, right? So again, looking at that and working at the workflow, it's very hard to get everybody all at once, but to even get it into production was even harder because certain groups wanted to have all their risks done, which was different from other. And again, maintaining that and updating that is it's a task upon itself that needs to always be followed up with on a daily basis because it's important, right? Because you don't want it to go through the loopholes. And I do agree with the paper forms because not only do they have that form, they have the new updated form, but they never include all of the correct risk and benefits. And half the time you get the paper form and nothing's ever filled out on the risk and benefits. It's just like a scribble and you're like, what does that mean? And you're looking at it going, is that death or is that and the alternatives, we have to, we have to comply. We have to give them the alternatives. If you don't do this, you could actually go and do acupuncture, whatever the other problems are that you could actually go seek alternative help for. And that is not captured in the paper. But when we do the digital and when we were running ours through, we wanted to make sure everything was gone through with all of our risk and benefits. And again, it was a stumbling block to get everybody, when we rolled it out, to make sure everybody was involved with the correct education, which was hindsight going back. Even if we did do it differently, I think those still little pockets and minute pockets still would have been missed, because we did a really good workflow before, and we did a tremendous education prior, and we let everybody demonstrate it prior to roll out, got everybody's input. But again, I think it's very challenging, but even after you've done it several times, you still run into problems.
I think one of the things we hear frequently is about physician adoption. Could you talk about, did you have a problem with physician adoption at Jackson? How did you solve for it? Can you give me any feedback or tips on that?
So with our new one that we just rolled out, all the physicians were all on board, and they wanted anesthesia to deal with it. So that was fun, because they were like, no, we have to have this buy-in from you. It's important. And they were just like, yeah, whatever they want to say. I'm like, no, you all have to agree. But when it comes to informed consent for their service line, they are so particular, and to the point of, this is exactly not the correct risk for this procedure. It's for the procedure that was 250 before. They literally go through every single one. We have a committee of just service line specific, and they go through every single one. And it's very tedious because they want it to be exactly right to the way they want it, which is great. But again, I love that idea that they really want to be involved and make sure it's correct. But it's at the point of, it's the same thing, different verbiage, different worded, and they still want it changed, which is nice. So we didn't have that much of an issue of them not wanting to do the work when it came to their service line. But when it was like a global thing, they were always willing to punt it to somebody else, which was very interesting.
Yeah.
They said, yes, we agree.
That's awesome. Stasha, how about you guys at UCLA? I know you did a big rollout there with your physicians.
Yeah. So when it comes to physician adoption, the most important thing that we have learned is involve physician leadership early and often.
Okay.
You do anything, you have to do that. And you have to have champions from each department, because again, kind of like what Kristen said, when it's a global rollout, you turn it on for everyone. That doesn't mean people are necessarily going to use it. You really have to have that driving force, probably of a physician leader at the top saying, this is what we're doing. This is when your department is going live. And one thing that actually really helped us is we built a dashboard with data and specified out service line and departments, so we could give our physician leadership information and say, hey, here is the percentage of consents that were done on paper versus the percentage of consents that were filed electronically. Here is the individual breakdown of who's doing it. And then they would they would have conversations with the heads of different departments or specific physicians. And you know what? It turned out sometimes physicians didn't have a consent that they could use. And we're like, okay, well, let us help you get that consent in there. Oh, they don't have signature pads in their clinics. Oh, let's talk about that. Some of their patients were older and couldn't use some of the features and writing the consent on an iPhone or however we have that up. Okay, well, let's look at upgrading so we can get a bigger screen for them. There's different things we know we need to optimize. And it wasn't just that they didn't want to do it. There were certain things that we need to work on. But in general, for most of our patients, we're now able to collect these signatures. We're able to file them electronically. Our lost consent percentage has dropped significantly.
Awesome.
So I think that's key.
Awesome. So from anybody, I'll start with you, Kristen. Like, can you share any like insight or best practices for kind of overcoming any of the challenges you have when trying to digitize the informed consent process?
So we listened to what the docs had to say and what nurses had to say, right? Because we need to hear from both, because it's important. Even though the doctors are the ones that do the consenting process when it relates to surgical procedures, we had to listen to what do they feel their obstacles would be. One of them were the signature pads, and one of the computers on wheel wasn't readily available where they were going to be getting their consents. So make sure that we had more of those readily available. The other ones that we had was they wanted to do it on their iPhone. If they were with a patient, would that be also available? So we wanted to make sure that we address all those stumbling blocks prior to. And again, just like Sasha said, we did have little groups and we had different people running it, right? But again, those were the little trickle down groups that didn't actually capture everybody. So I would have to go back and do individual education with them. But if you have to listen to not just what the docs need, but also what the nurses need, because again, they work together. And we realized listening to them and looking at the different workflows, we were able to get them the extra pads, make sure they had the iPhone access, make sure if their clinic was across the street that they would have that availability to do it. Because papers, like we all talked about, they get lost. And if somebody comes in like Joint Commission, CMS, or ACA comes into your door and they want to see the consent and you're like, oops, we lost it. That's not a good answer.
Right.
We hardly ever use paper consents in our area except for downtime or an emergency situation. But even then we use our iMed for all of our consents, even emergency. And we find it, even with the process of as soon as you get it, you have to scan it in with that unit. We could still lose them. But listening to the stakeholders and the nurses is key in order to roll it out without any obstacles, which seems to work for us at Jackson.
That's great. Stesha, how about you? Any best practices or insight you could share?
So I would say making sure to understand your current state workflows before you implement a digitized process. Because if you don't understand the current state of your workflows, it's very difficult to get people to adopt something that's too far off the beaten path. So also understanding the current workflows also helped us from a technical perspective of how to build out an electronic workflow, how to align our interface, where our access points are, and then also where are people consenting, because we can't afford to place a signature pad on every computer everywhere. But we can prioritize the locations we put them if it's a hot spot for consenting. Some of those other areas we can use other types of technology or different methods. But for those areas where do a high amount of consenting, it makes sense for them to have a signature pad. I would also say for us implementing the signature pad, that was very difficult as well. I think it's important to do evaluation and testing and making sure that you pick one signature pad for the organization, because when you implement different signature pads on the server levels and the desktop levels, that can become very, very difficult. But if you use the same type of signature pad across your workflows, because I know Epic and Cerner have admissions consenting, which is different than procedural consenting. We have other types of consenting available in these large electronic medical record software companies. And so if you're able to use the same signature pads across all platforms, it really helps the efficiency in streamlining those different workflows, even though they may be a little bit different. But technically speaking, it'll make the end users a lot happier, because you will never meet a more dissatisfied person when they complete their consent process, they're ready to sign it, and the signature pad doesn't work. They can do everything right, and then if you tell someone they have to go get a new computer with a new signature pad, it's not going to happen. Yeah. So we have to make sure that those work as often as possible.
Awesome.
I'd also add one more thing that I think often gets overlooked in implementing really anything from a digital perspective is we have to get the feedback of the patients too. Sometimes the font is too small for them. Sometimes they can't read it. It's just not working for them, or it's just tedious and it's taking too long. I think it's important to try to, especially from your older population or ones with just any sort of disability whatsoever. I think it's important to get their perspective, just to know how it's going to work in workflow from an experiential perspective.
Awesome. Spoken like a true patient experience officer. Thank you, Courtney.
Yeah.
Courtney, this one's for you. So crystal ball in front of you, and I said, hey, what's coming from a legal, regulatory, and accreditation landscape for informed consent? Do you have any insight or thoughts?
I just hope it catches up, to be honest with you.
Wow. Okay.
I think the legal landscape is way behind when it comes to, we're moving to email and texting and other ways of keeping patients informed and up to date and checking in on them. And just from a regulatory perspective, I think it's way behind. I don't think it encompasses really anything on the digital front. Whereas if they only spent some time actually interviewing patients and talking to patients, what most regulators would find is that they just want convenience and ease of access more than anything. And that's not the way the regulatory framework is built. It's built so much with an emphasis on preventing lawsuits or mitigating the chances of lawsuits that really never had a high incidence to even begin with, that they lose sight of the fact that most of us, clinicians and healthcare professionals and patients alike, and just community members alike, we care about convenience, ease of access, and immediacy. We like things to be very available very quickly. And I think that's actually why many hospitals are struggling to meet patients' expectations post-COVID. We can't move nearly as quickly as some of these more agile, smaller fields. Healthcare just doesn't have that same level of immediacy and convenience. And that's why some of these boutique shops like CVS and others are just, or an Amazon are just starting to outpace us. So we've somehow got to become more agile. The regulators need to keep up, and they need to recognize where the patient's perspectives are and the community members' perspectives are, and kind of really minimize some of the constraints that we've got that keep us away from using the digital world in to the extent we should, really.
Right.
So people are fearful of texting and emailing, and it's all got to be behind all these portals and mechanisms that patients don't want to go to, won't go to, can't stand going to. None of us want to remember the 15,000 passwords we've got to remember. And it's just, there's a compromise between security and convenience that I think we lose sight of. And it's hurting us from a patient experience perspective.
Yeah, it's an interesting perspective. So let me ask you this, coming from now that, since you're in Texas and you are one of the states that actually, put the Texas risk in place, do you see, we know Boston has a little nuance to their law. We know Pennsylvania has a little nuance to their law, nothing like Texas risk. Do you see those type of, I'll call it government involvement, if you want to call it that, or at least, do you see that going more nationwide other than just in Texas?
Honestly, I don't think so, because it drives the clinicians nuts. I think the impetus probably started from them. They wanted some enumeration of what they should say to not be sued, or at least to not have the lawsuit successful. Anyone can sue for anything, really.
Right.
And so there was probably an initial impetus by clinicians to try to get everything just labeled out for them, but it becomes so tedious. I don't know if you've ever seen a Texas informed consent, but it's just,
I have.
it's just brutal. It's page after page after page. And even when we try to make it as efficient as possible, it's labor intensive, and
Right.
it drives everyone crazy in the end. I think most states, God bless Texas, we try to take the first hit on a lot of major things like COVID, and try to really set the lead medicine and set the path. But that's one where I hope and believe states have realized that was great for you, Texas, to try that, but didn't really work in your favor. So maybe we won't do it. I will say we've got very few lawsuits associated with it, but that's because of tort reform. That
Right.
really doesn't have much to do with our informed consent provisions. So I hope not, is what it comes down to at the end of the day.
There you go. So I must have failed geography. I said Boston. Massachusetts is the state. Boston would be the capital of the city.
I knew where you were coming from.
Whatever. It's a long time since my Rutgers education, so I've been out of school for a long time. So, all right, let's just kind of round the horn one time. Kind of just final thoughts, any advice, any just commentary. Courtney, we'll start with you since you have the floor.
Yeah, I think my commentary for really everything in the digital world is you got to be patient. It's going to be very tedious to roll out. Informed consent in any patient education requires a major orchestration between a lot of different stakeholders who typically don't like to build consensus, frankly. Trying to get consensus across service lines is very hard to achieve. And sometimes it just requires a lot of patience and insistence and flexibility and listening and willingness to come back to decisions that were previously made, coming back to the decision board, the drawing board, to say that didn't work, let's try this. You almost need these little quick, rapid cycles of review from a study and design and analyses and following up to see what's working, what didn't work, and what do we need to try now. And I think we lose a lot of people in that process. And sometimes they're not always quick to adopt because of it. It was just so hard to roll out that we almost lose them in the adoption. But once they see the wins and the wins for them, then they come around.
Yeah.
And that's really, I mean, that's my take home message for all things digital and patient centered. They've got to see the benefits. It's got to be immediate. And it's got to be a win for them. And you got to keep the messaging clear that you will listen to them, that you will modify things, go back to the drawing board, and that it's their perspective at the end of the day that's driving a lot of the decisions you make.
Awesome. Thank you. Kristen, how about you? You have a final thought?
So I do agree with what my colleagues have been saying in regards to making sure you get everybody to opine on the process and not to be discouraged, because we've rolled out and we're about to roll out another thing with our consenting process. And it's very tedious, but again, making sure that everybody is happen and making sure that when we do roll them out in that certain area, that you've talked to the stakeholders and what is one of their stumbling blocks that they might be having, or what did they have with the last one that maybe we could prevent with this one rolling out. And it's important, and it takes some time, and to be okay with going back to the drawing board. You know what? This rollout was awful. Let's start from scratch again and see what else we can do. Because, no matter how hard you try and you can have everything all ready and set, and you can always hit some sort of hurdle that you never thought would come across this way. So I think it's just taking the time to make sure that you have, perspective, that you might have to go back, and it's okay, But again, to stick to the guns to finally get it to roll out the correct way is important.
Thank you so much. How about you, Stasha?
So I agree with what everyone's been saying. I think one thing that Courtney mentioned earlier that I think is really important is we do have a patient advisory council. I do think it's really important to hear what patients think. One thing that we're working on that we would like to work towards is always having their consents available in their patient portal. That is something right now that is very difficult to do unless a provider sends their consent electronically. It involves an extra step for the provider. But when we're building an interface, that's something that I think people should think about in the future so that patients can not only sign them, but see them. And so I do think the feedback from the patients is important, especially from a range of ages, languages, cultures, because they're all going to see it a little bit differently. And I think this process hits so many patients that experience piece for patients is really important, that they understand it. And I think it's something we're all still working on. But I think in the future, that's something that we're trying to improve so that everyone has a positive patient experience. But I do think that is tedious. I do think it's a lot of work, and it involves a lot of different people to make that happen.
Awesome.
Yeah,
Thank you.
I just want to
Go ahead,
go off
Kristen.
what you just said, Sasha, which I'm very fortunate to work for Jackson because we are very patient-centered, and our patients are able to see everything in their record right away, all their consents, everything. So we have patients come up and say, oh, well, my last consent, and I signed it on this date for this. They're very informed. So again, I think that where we're so used to it, we take it for granted. But we're very fortunate that Jackson is very on the forefront to making sure that their patients feel not only heard, but also feel welcomed and wanted at Jackson, because they know that their voices are always heard. And if they can go and say, you know what, we thought about this, and we really take it into account. We do have our patient advisories too, which again, hindsight's 2020. I should have spoken more about it, but it's again something that we take for granted here at Jackson. We're very fortunate with that.
Awesome. Thank you, Kristen.
There's one more point that we should probably make that I don't think we've brought up, which is, and I hope everyone on the line recognizes this, I hope everyone in every audience always recognizes this, is that sometimes projects and rollouts fail for nothing that has to do with you as the implementer. Sometimes it's just the culture or the timing or one particular strategy didn't go right. And I think a lot of us who take on really large system work, we sometimes forget that, and we're very hard on ourselves when something doesn't just go out as smoothly as possible. All you can do is plan and come up with as many contingencies as possible and be very inclusive and involve the right voices at the right time and hope for the best. And sometimes things don't go well, and sometimes you need to actually sundown certain projects that aren't working for you and maybe even start over. And I wish there was more discussion on that, because I think people are under the impression that healthcare always just kind of rolls out marvelously and smoothly, and God, no, it doesn't. So I hope they realize
Exactly.
that.
Well, thank you so much, Naomi. Do we have any questions for the panelists before we wrap up?
We do not actually have, actually, yes, we do. Sorry, one just came in.
Okay.
So Cindy asks, you've talked about healthcare being slow to come to the table or our industry having technical laggards. What do you see as the impending event, or what will it take to move the needle, to move the industry more than just tiny baby steps?
That's a really good question. I would love to say I have an answer, but I'm not really sure I do, other than saying where I think we are a little bit behind in healthcare, is that we're very siloed. Every department kind of works within themselves. Then service lines don't always coordinate with service lines. Inpatient doesn't always coordinate well with the ED, which doesn't always coordinate well with the post-operative side. There are different teams involved in each aspect. And the patient can feel the disruption and the continuity of care. We even have many vendors involved to try to, and vendors don't often, their systems don't always talk to each other. So it's not all that unusual to have 15 different vendors involved in an aspect of the patient's care, and there's no actually interoperability between them. To move around that, I think we just have to be more deliberate about really mapping the patient journey and realizing where the disruptions are, and using technology to recognize where those disruptions are and trying to talk to each other to help smooth them out. We have to do that almost proactively and more deliberately than we might otherwise do. So, for instance, I focus primarily on inpatient, but for the inpatient experience to go as strongly as possible, we have to coordinate with the physician organization who works primarily on the outpatient side. And so we have to meet monthly to make sure that we know what each other is working on and how it can impact the patient journey. So, and that, fortunately, there are a lot of technologies now that are coming into play to really help us map out the patient journey. But I honestly don't think we have a solution yet. I think we're moving there as healthcare, but at least we recognize the problems. I mean, I think we're at least at the awareness stage. It's just coming around the solution corner that I'm not sure we're there. COVID really accelerated us. COVID taught us that we have to move quicker. We have to be more agile. And I think we came a long way. Many of our hospitals rolled out tons of vaccines very quickly, led the way, and that was a lot of digital workplace really driving a lot of that. So I'm proud of us. It showed we can do it. Now we need to do it with all sorts of things.
I think that also might be a question where that kind of pulls in the conversation around diversity, equity, and inclusion. Because in our organization, not all of our patients have transportation to their visits. Not all of them have a reading level over 8th grade. Not all of them speak English or have someone in their family who readily speaks English. So I think we have a long way to go across the country in this environment, especially because I think EDI principles and ethics, they're highlighted right now, which I think is really good. But when I think it comes to consenting and the future of consenting, I think it's really going to be around how are we going to get the information appropriately to everyone in a way that they can understand? I don't know if there's some impending event that's going to push that needle, but I think it's happening. I think it's slowly happening, but I think it's something that everyone's working toward. But I think this is a difficult concept because we're trying to make sure that everyone has what they need. And I think it's very difficult for healthcare organizations because everyone's needs might be a little bit different. So how do we, with the stuff that we have and the limited time that we have, make sure to address everyone's unique and individual needs? And I think that's an ongoing conversation because right now we don't have enough clinicians as it is. So how do we accommodate all these needs with our current level of staffing?
Thank you. We have another question, this is an interesting one as well. Has anyone done a financial impact assessment before and or after implementation of the digital consent? And how have patient satisfaction scores been affected?
I can tell you the patient satisfaction scores. Can't tell you the financial impact, unfortunately. Maybe my colleagues can. Patient satisfaction scores always improve when anything becomes smoother, when pain points become smoother. Our own experience is that when you compare patients on a digital platform compared against patients who do not receive a digital platform, we see pretty big differences in scores, in what we call HCAHPS scores or patient satisfaction scores, particularly as it relates to physician communication, nurse communication, which are two domains on HCAHPS, and overall score. And that actually goes for patients that you might not actually think would always like the digital workplace. I do not think it's the case. We know it's not the case any longer that older patients are unwilling or unable to access email and texting and computers. We're also finding that digital gap or digital divide between ethnicities is very slimming down with the digital workplace. So those disparities are less exacerbated. They still exist, but they're less exacerbated. So from the patient experience perspective, I would say definitely better. I'm afraid I can't speak to the financial impacts. I don't know if my colleagues can.
No worries. Kristen or Stesha, any chance you know the financial impacts of the before and after?
I don't have specific numbers. I can tell you that there's costs associated with implementation, which include whatever software you're going to use, the IT resources you're going to use, depending on how your organization pays for that. And then also devices, for example, if you need more computers, signature pads, and things like that. Long-term, we have seen definitely positive patient feedback. I don't have any research around that or specifically tying consenting and our HCAHPS scores. Our patients don't always enjoy surveys, so we didn't do anything specific.
Imagine that.
We don't want 500 of them. That's what they're getting right now sometimes.
100, they're like, no more survey. Yeah. And so, but in terms of financial impact, we would see it in our liability risk and less lost consents, and also consenting when a patient comes back and said, I didn't know XYZ in this surgery, and it's clearly listed out in risks and benefits. I don't have a financial impact statement for that. I know it's decreased. I don't think anyone in our legal department has compiled the exact numbers of pre and post. I think it's difficult because each one's a little bit different, but that's where we would kind of like decreased readmissions. We're seeing like decreased benefits or increased benefits on the back end for things we're not seeing anymore, or things that we don't have to deal with as long as anymore because it has a better documentation behind it, but I don't have specific numbers.
That's all right. Awesome. Thank you so much. Damien, you asked, when did informed consents begin? 1960, curious of the origin. Our friend Dr. Fink was nice enough to answer. The initial legal precedent for informed consent was published in 1914, so a little bit before the 60s, but it's been around a while. I thought this was interesting. Dr. Fink, who has worked in the field for a long time, said, patient comprehension is a critical component of adequate informed consent. In the Veterans Administration, in the VA, where the iMed solution began, the practice often involves sharing an unsigned document with the patient to allow them to be more informed and ask targeted questions. This practice is clearly facilitated by using a digital platform. just an
Yeah.
interesting concept. The VA obviously has a very finite group of patients, and their physicians are all employed and all, but the concept's still the same of how do we really take a process that was super paper-based intensive and then make it digital, and this conversation and capturing it digitally. And so I just thought it was a great story. Thank you, Dr. Fink, for sharing that.
I think it's also important that we point out that more information is not always better from a comprehension perspective. There
Oh,
is
true.
such a thing as just overwhelming somebody with information. And that's where I kind of think Texas might have gotten it a little wrong with the informed consent. Is there's so much detail that it's almost it's just above most of our patients, most our patients being patients, not our willingness to put up with something. That's the kind of patience I mean. Is that we all have a certain amount of time that we're willing to listen, and then we're just over it. And that is, I think we lose sight of that a little bit in informed consent. It's less about giving a whole bunch of information, and it's more about that interactive dialogue where you actually purposefully invite the patient to ask questions that are well targeted based on what you just said.
Awesome. Thank you. And with that, I'm going to wrap and thank our panelists, Stesha, Kristen, Courtney. You guys were unbelievable. You're awesome. Thank you for participating in this. And Naomi, great job hosting. All of our participants, thank you for attending. If you want any the videos or the recording, we can be more than happy to send it out to you. Put it in the chat function or in the Q&A, and we'll be sure to get it over to you. Thank you again, everybody, and appreciate your time. Take care. Have a great day.
Thank you.